Hi everyone, welcome back to the Ask an Expert series here at Kintec. My name's Dr. Michael Ryan. I'm one of the pedorthists here as well as the Director of Research and Development for Kintec. I'm here for the next half an hour or so, or 30 minutes, just to answer some questions that you have on foot health. Also make you aware that this is the second in our series, so we did our first sequence on this on December the 2nd, where we answered quite a few questions, and I'll actually be referencing a couple of my answers today on the responses to some questions on that December the 2nd post. Just to like to remind all our viewers that we do have show notes available on the Kintec blog, blog.kintec.net. So there's a couple things that I'll be referencing, some videos and some references. I always like to use references so that you think that I'm not just making this stuff up as best as I can. We have a fair bit of questions to get through today, so I do apologize if I'm not able to get through all of your questions, but we'll certainly do our best. So the great thing about Facebook Live too, I'll remind everyone, you feel free to write me questions in as we go through here, and I can answer them then while you're on the session. So I have the first question from Laddie, who asks any advice for a very painful heel bone spur that from a friend of his has. 2 surgeries apparently have been recommended for this case. The first surgery is to address a bunion that has developed in the same foot, and the second surgery is for a tendon that attaches to the heel after the bunion surgery has healed. We'd love one surgery if possible, but it looks like that is not possible by the surgeon. Apparently this friend of Laddie also wears orthotics. What can we do? I think in this case it's good to differentiate the bunion from the plantar fascia and the painful heel spur. They're possibly 2 different things. Bunion surgery is often used just to address the alignment of the big toe, and more specifically the alignment of this bone here, the first metatarsal. Often this is deviating too much to the inside here, and the surgery is often done to try to bring that back into a more corrected alignment. A heel spur, on the other hand, is happening on the heel, and this is something that is commonplace with chronic plantar fasciitis. It's actually common in a lot of overuse soft tissue injuries where we do see calcium deposits become embedded within the soft tissue, within the tendon or in the ligament. And you would see it, if I can get the right video angle here. This little projection here is where the plantar fascia originates. This is often also where the pain is, and this is where you often would see the heel spurs. Contrary to popular opinion, it's not actually the heel spur that's often causing the pain itself, the way that you might think that you're stepping on a tack. It's the the increased sensitivity of the nervous system through the ligament, through the plantar fascia, that's often driving that pain. And I know, working with some radiologists in St. Paul's Hospital, we looked through 267 cases of plantar fasciitis, and a lot of those cases resolved with therapy, and the heel spur persisted, which is good news in the sense that you can get better in spite of having a heel spur, but it's worth knowing that the heel spur likely isn't going to go away. It will likely be embedded in the ligament, but it shouldn't cause you problems. I'll refer to some other questions later on about how to manage persistent plantar heel pain, if that's indeed the concern you have here, Laddie. With respect to the bunion surgery, I'd agree that one surgery is often better than 2. Certainly do your homework as far as researching the type of surgery you're doing. Be sure you're aware of the post-surgery implications. Often the post-op recovery time is quite lengthy, taking several months. So just be prepared for that, and possibly seek a second opinion if needed. Remember, you're the one in the driver's seat when it comes to seeking the information in this, and sometimes you can have different responses based on whether it's a podiatrist or a foot and ankle surgeon. Carol writes, why do my feet cramp up from my heel to my big toe? My big toe separates from the rest of my toes in an incredible painful way. Please let me know what I need to do. I already have orthotics from Kintec to help me walk every day. This is so painful. Yes, I get calf pain sometimes at night, and there's hardly a pain like it when that comes on, and I can imagine that it's truly painful, Carol. It's hard to truly put your finger exactly what's causing cramping. It's suspected a few different things could be the source for that, and a lot of times it is individual. So as far as what to rule out, any one of three different things really. One is make sure you're hydrated. General level in terms of your water table in your body. Should you be dehydrated, that could be a factor in cramping anywhere in the body. Related to that is the discussion of electrolytes. That's received a lot of attention in media. I think in particular sodium and magnesium are important electrolytes to help with that. Not so much sodium, so it's potassium and magnesium that are the important. Some people will supplement themselves with potassium and magnesium for that reason and notice good effects. So it's something to try on your own side to see if that benefits you. Why the foot and not other muscles as far as cramping? I personally think fatigue in the muscles has an important factor in this, and that's something that might warrant having somebody look at your feet and assess whether there's aspects of your foot posture that might be leading to why your feet are as tired as they are. Muscles are a little peculiar in the sense that when they get very, very tired, their ability to control their tension or their toneness starts to decrease, and so the leash, as it were, from the brain starts to get longer and longer, and sometimes it just snaps, and the muscle is effectively on its own, and then just contracts and is overactive. So in fact, it's the brain that calms the muscle and keeps it quiet, and so when that connection is interrupted in certain ways, and fatigue is one of them, it can make the muscles just go crazy. So I'd look into those aspects. You can always try just supplementing with some over-the-counter potassium and magnesium, either tablets or you can get it in a powdered way that you can put in your drink and see if that makes any difference. But that is a painful condition, of course. Next, Tracy writes that Helix Rigidus footwear and physio recommendations. Helix Rigidus is something that we see a lot in the pedorthic clinic, and it's often on its own something worth addressing because of its implications on our movement. It's the big toe is an important part of how we move forward. The big toe, the ankle, and the knee are some of the joints that move the most during walking, and so when the big toe doesn't move, that makes it hard for the ankle to move, and consequently the knee can't move, and so a lot of that load gets shifted to the hips and the back, and that can lead to then back pain and hip pain. So a way that we address that with Helix Rigidus and its cousin, if you will, first osteoarthritis of this joint, and this joint here I'm referring to. And so Helix Rigidus, in Latin, the big toes fancy name is the Helix. It's kind of a cool name. It's like the Australian pickup, the Hilux, but with an A. and two L's. So yeah, it's when this joint doesn't move, and so when we try to flex it upwards, we're not able to in any way. And so one of the reasons for that is often when there's osteoarthritis in this joint, and that means when the joint can't move, but it's often asked to move by the foot, and it creates a lot of joint pressure, and that builds up, and there's pain because of the pressure on either joint surface. There's a number of ways that we can address that. With Halix rigidus, it's really important to splint the foot. We're not going to get any range of motion out of that joint, so there's no point in trying to force something that's not going to move. Instead, what we often do is we'd start off with a product like this called a gate plate. This is made of carbon fiber. It's quite small. It comes in a variety of sizes, and it's something that you would then simply put inside of your shoe. So you would just lift up the sock liner of the shoe and then put the gate plate underneath, making sure it's of course the right size. And in a shoe that, like any shoe, you might see that it has some flexibility in the forefoot. As you are toeing off, the foot is extending over the toes, and this is causing that compression on that joint, and we want to limit the foot's ability to do that, or the shoe's ability to let the foot do that. And this is where the gate plate, that is very stiff. These do come in different stiffnesses as well, so it's something to try. It's great because it's something you can transfer across different shoes, and is very versatile in that respect. They're about $50 retail at our locations. If the gate plate doesn't work, or you need something depending on the shoes you have, the next level up in terms of support for you would be to consider having a shoe that has a significant forefoot rocker. Now, the Hokas that I showed in the last Facebook post, these are great. These illustrate very nicely a fairly significant forefoot rocker. I'm referring to this sloping upwards of the shoe, the front part of the shoe. The sole also has to be thick enough for this shoe to be able to roll far enough forward so that you can walk at a normal speed and not have this interrupt you too much. If you try to do this on a shoe like this that has a standard thickness of sole, you get to there only, and so you would really need to extend your foot in order to keep moving forward. And so a gate plate in a shoe like this may or may not be enough. You might need to have a larger rocker such as this, or consider adding a rocker to your existing shoes, and that's something that we can do. Something not many people think of doing either. It's relatively inexpensive. Costs would vary between maybe $60 and $80 for a shoe to be done, and we can add a custom thickness here and the slope, any slope that you like. We can match the color with the sole of the shoe, and it's something that can dramatically decrease the pain associated with arthritis in that big toe, and just helping with the function. We do that with running shoes, standard shoes, boots, you name it. So consider that, those two options for Halix rigidus, a great tool. Right, so if anyone has any questions, just a reminder, so you're on Facebook Live with Kintec, Ask an Expert. Feel free to text or type in any questions here to me, Michael Ryan, while happy to go through them while we're live here for about the next 15 minutes. Next question's from Jackie. Thank you, Jackie, for writing in. These are great questions, I should say. It's happy to try to answer everyone's foot problems here, or shin problems. Jackie writes, currently experiencing shin splints as I increased my mileage for a hilly race back in October. I took time off and waited for no pain and discomfort, and I started back with slow, then faster walking on the treadmill with no pain or discomfort. Then I went running on the road 3 times over a 5-day period, and on the 3rd run my shin started to hurt a lot. What would be a safe return to running once the pain stops? Also, besides stretching the calves and foam rolling, any other exercises I should be doing to help strengthen and heal my shins? Great question, and this is something that we see a lot, and is something discussed a lot in the running literature when it comes to running injuries. Shin splints has been, the name shin splints has been the bane of sports medicine physicians for a few years now, in the sense that it's not very specific. Shin splints could refer to a collection of different conditions. Medial tibial stress syndrome, so this would be pain along the inside shin bone itself, caused by muscles pulling too much on the lining of that bone, the periosteum, causing some irritation and inflammation. It could also be a stress fracture of the bone itself, which is small, tiny areas of stress in the bone that caused by excessive loading. Or it could be a compartment syndrome, which is rare and uncommon, but it's possible because it's also in the shin area, usually closer towards the knee. Probably, Jackie, the first response to your question, based on what I know here, is depending on how bad the pain is and how the type of pain is, it's worth having this looked at by either a foot orthotist to come in and see one of us here at Kintec, or your physiotherapist, because you do want to screen that it's not a stress fracture. These are relatively common among runners, particularly a bit more common in women than men, and depending on your age, there may be a bone mineral density component to this, depending on your sort of metabolic background. So those are things worth screening for. It's also worth noting that x-rays are not terrifically sensitive to stress fractures, so you might have an x-ray and it's negative, but you still have a stress fracture because it's not seen on the x-ray. It's not actually visualized as a hairline fracture yet. So you may need a discussion then with your family doctor for a referral for a bone scan, where they see the uptake of a like a radioactive isotope. It sounds worse than it is, that you ingest in very, very small quantities, and then you stand in front of a screen and it sees how much of this isotope is taken up by your tissues, specifically your bones, and then you can see if certain areas of your bones have taken up more of this, then this suggests it's a hot spot and likely an area of stress, excessive stress. I think you can also get a CT or contrast CT on the area as well, as directed by your healthcare professional. So firstly, I'd screen for the stress fracture once that's ruled out and it's felt to probably be medial tibial stress syndrome. I think that it's good to wait a period of time until that pain settles down. You want your pain to really not be any higher than a 3 out of 10 for your activities. I'd want you to be able to hop without any pain before returning to any walk-run program. And then as you progress, probably start walking maybe 3 minutes, running 2, doing this 2 to 3 times, once or twice a week. See how your shin responds to it. You should ideally end your run workout without any pain. You might be bored because you don't think you're running far enough, but it's important to think of running more as a rehabilitative exercise than one for conditioning. So do your run, your little run walk, and then jump on a bike and pedal your heart out to then get your endorphin rush, or go to the pool or so on. So it's important to sort of listen to your body that way. It also depends on how severe the pain is in your shins. But using a run-walk program is a great tool to get you back to running. And consistency in your training is really important. So doing that week over week, within a couple of months, you'll be back stronger than you were before your injury. Elizabeth writes, "Hi, I am currently putting my orthotics in my shoes and boots, but for some reason my ankle seems to roll to one side. What can I do to keep my ankle from rolling even though I'm wearing orthotics?" And this is also a really good question, because it's something that we like to screen for when we're looking at the fitting of an orthotic, or certain times when people come in for an adjustment. Because of the nature of orthotics providing support through the arch, one of the things that I would always tell a patient, I do not want you to feel that your foot's turning outwards or inverting. And what I mean by that is if you've got your foot here, and this would be my left foot, for instance, that my foot's tilting this way, outwards. So this is a common way that people might sprain their ankle, so that the inside of the foot is opening up. And if we're pushing too much in the arch, then it might feel like you're walking on the outside of your foot. If you feel this way in your orthotics, I'd say go back to where you got them, tell whoever made them for you that this is your feeling and they should adjust them as needed. A couple things that we might do if you were a Kintec patient coming in with this, I would probably, this area of foam at the back here, I would grind this area down and evaluate how that feels. That takes about 30 seconds. If that's not enough, I might even remove this post entirely, which will then make the arch area here more compliant. And that will hopefully make your center of pressure more balanced when you're in the orthotic. We then have to evaluate things after that, but a series of adjustments could be made, and this is something that it's worth exploring and certainly warrants follow-up. We don't want you to be walking too long feeling that you're walking on the outside, because you would be using muscles on the outside of your shin too much, and they may become sore. You may be having too much pressure on the outside part of your foot, also might lead to soreness, or probably the worst might be that you might sprain your ankle if you're doing sports, ballistic sports and that sort of thing, which would be really bad. So something to look into. And thank you again for everyone's questions. Feel free to, if anyone has any further questions, if you're already on Facebook Live now, feel free to text me and follow that up. Diane writes, why do I get shooting nerve-type pain on occasion when I put my foot down? It shoots up my leg, and it happens in shoes or barefoot. Yeah, this is good to follow up with for sure. Any sort of nervy type pain, as distinct from muscle pain or soft tissue type of pain versus joint pain. There's certainly different types of pain. Nerve pain feels a bit more electrical. It can be tingling and it can radiate. It can also feel hot or cold. And those are things that might tell you that the nerves themselves may be involved. When it comes to shooting pain, that's often that radiating pain. So it might start in the toes and move upwards or move down the leg into the toes, which is more common. And I think in this case it certainly merits having someone have a look at what's happening, what sort of movements cause this pain. You say when you're putting your foot down, I'd like to explore that a little more with a squat and just the type of posture that your knee, your hips, and your back are in. A few things that we'd want to screen for here are any impingement or entrapments of nerves at various levels as they come out of the spinal cord or from the spinal cord themselves. Physiotherapists are particularly good and well trained and differentiating this, as are chiropractors. So it might be a good idea to, if you know one, have them have a look at this pain and follow up with them on that, because it may be something that originates from the lower back that's manifesting itself in your leg or in your foot. Gita, forgive me if I'm saying your name wrong, is there anything she's imploring me I can do to speed up healing of the plantar fascia? It was injured in mid-September. I cut back running, she writes, drastically to nearly none since then and attended weekly chiro and infrared treatments. Careful attention to foot and calf stretches every day. And so, this is certainly the bread and butter of a lot of what we do at as a pit orthist and at Kintec in terms of managing plantar fascia pain and just chronic plantar foot pain. Our previous blog does discuss this to some extent, just to review a little bit of that, what we talked about. I think the careful balance of both using a good orthotics to help reduce stress on the foot, coupled with good footwear. So footwear that is typically quite soft, so a shoe like this, if this is your everyday shoe or a shoe that you're working in that's very flexible, this is going to add a lot more stress on your plantar fascia if it's throughout the day, and that's something that could be making it harder for that area to heal. Better to be in a shoe that's a lot stiffer than that, or ideally even a shoe that has a bit of a rocker to it, provided it fits well and is comfortable. So don't ignore the footwear aspect. Certainly consider using an orthotic to take stress off the plantar fascia. And I'll also refer you to the exercises that we use a lot of times, and that we had worked with Scott Fraser, the physiotherapist at UBC, to develop a great plan for people with plantar fasciitis that do work for long periods of time. So you don't have to be working on your feet to benefit from that program, but it's something that we wanted to target, especially that group as well, because it's something very common in workers who do stand. So this will all be on our show notes on the blog here, so check that out on the Kintec blog afterwards. I'd say as well, I'd offer, if you do try those conservative treatments first and you find that they're not successful, then I would follow that up possibly with a referral to a sports medicine physician. I know the clinic at UBC, the Al McGavin Clinic, have a great program for managing foot pain. They can do prolotherapy or PRP injections at a relatively inexpensive cost of around $300. So the assessment itself is free. However, you would be paying out of pocket. MSP does not cover the cost for these regenerative injection treatments, and they are very successful in managing and helping people that have otherwise failed conservative treatment. It's usually simply an injection that's palpated, or you can go to Canada Diagnostic Centers, and they use ultrasound to guide. That's a fee-for-service private clinic. Costs about $1,500 for an injection treatment into the plantar fascia, and these are meant to stimulate regeneration of that plantar fascia, so are certainly a worthwhile. And I can add some work that we did with St. Paul's that I should mention. Mark Cresswell and his team is in the radiology department at St. Paul's does just great work with ultrasound guided injection treatments for both plantar fasciitis as well as other overuse tendon injuries. They are free. They are referral based though, and so there is a bit of a longer wait list, I think, to get in to see Mark at St. Paul's. But we'll put in some of the research that we did that shows some great outcomes in people that didn't respond to conservative treatments for this, but did respond very well to the other ones. I'll just finish up our last question here from Kyle, who has experienced plantar fasciitis for 3 years, and this is a great question, Kyle. Here it touches on, I think a few people have raised this question to me over the last year or so. He writes, his pain has not improved despite wearing orthotics, and he's tired of his mobility being compromised. I've recently learned of the theories proposed by Katie Bowman that suggest that orthotics, arch support, inclined shoes, etc. are acting like a cast for our feet and have devolved them, it's a big word, into dependence on these various supports just to mitigate pain. I'm wondering what your take may be on these theories, and realize that you will also likely not answer these questions because they do not support our financial interests. Well, here we go. Here we are addressing that. That would be a shame, but I'm hoping you will surprise me. So let me surprise you, Kyle. Yeah, and I think this is an area that there hasn't been really any research to give us any guidance as far as the ability of orthotics and other tools that are meant to reduce stress on the plantar fascia and soft tissue on the bottom of the foot, and whether that does indeed change the material properties of these tissues. I suspect that, as I mentioned in the answer to the previous question, the best way to resolve plantar fasciitis is through a two-headed approach. One, to reduce stress on these structures using, as you suggest, shoes, orthotics, etc., as well as the other approach through proper tissue rehabilitation. Generally speaking, at Kintec, we should be advising you to have that balanced approach and not simply rely on the orthotic to do all of the work and to be a one-stop panacea for your foot pain. So I would say that I think it's a theory at this point from Dr. Bowman with respect to the devolving of the foot after using an orthotic. That still needs to be supported by high quality research, or any research really. It's a difficult area to do work in. The foot's certainly a complicated structure, and it's difficult to assess it really well using modern biomechanical tools. But I understand where you're thinking, and I think that's, for that reason, it's important that we not, as I said, rely on the orthotics alone, but use proper stretch and strengthening, encourage patients to listen to their body, and if you had any concerns regarding the use of your existing orthotics, certainly come back and talk to any of our pit orthotists, and we'd be happy to outline a plan for you in that respect. So I think there I will call it. It's our 30 minutes is up, but I would certainly want to thank everyone for these are great questions. Happy to answer them. If anyone has any comments or questions, feel free to touch base with us on our Kintec post. Again, it's Michael Ryan with the Director of R&D here at Kintec and a certified pit orthotist. So we look forward to touching base with you next time we're on Facebook Live. Thanks again.